everyone. Thank you for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation. CPBF is a charitable organization, and our mission is to support and educate families of premature babies. This Preemie Chat series is one of the many initiatives we have to bring information for NICU families and healthcare professionals. Here, every Friday, we talk with experts, researchers, and parents who share with us their experience and knowledge. Also on our website, canadianpreemies.org, we have all kinds of resources and support. For example, we have the COVID care program. We are offering free therapy sessions for families who are currently in the ICU or have been discharged up to 1 year. All the information is on our website and registration is free. And today we are going to talk about preeclampsia and maternal health after pregnancy. Preeclampsia is a serious pregnancy complication, and it's dangerous for both the mother and the unborn baby, both during and after pregnancy. Preeclampsia is characterized by high blood pressure and often protein in the urine. Affecting 5 to 8% of pregnancies worldwide, preeclampsia is a significant cause of maternal death and preterm delivery. Importantly, women who develop preeclampsia during pregnancy are more likely to develop a cardiovascular disease across their lifetime. In this session, we'll talk about the causes of preeclampsia, its signs and symptoms, and risk factors for this disorder. New emerging research into our understanding of this disorder will also be highlighted. This session will also cover the associations between preeclampsia and maternal cardiovascular health in later life, highlighting postpartum programs and intervention strategies aiming at reducing this disease burden on women in the Canadian context. We also have a parent, Tiffany Richards, sharing with us her experience with preeclampsia. But I'm gonna have here joining us live Dr. Samantha Benton, who is a postdoctoral fellow at Queen's University. She completed her doctorate degree in reproductive and developmental sciences at the University of British Columbia in 2014. Her research focused on novel blood biomarkers for the prediction and diagnosis of preeclampsia and fetal growth restriction, two serious complications of pregnancy. She completed her postdoctoral training at the University of Ottawa, and in 2020, she began a second fellowship at Queen's University. Her work is currently focused on examining placental function in an animal model of fetal growth restriction. Samantha, thank you so much for joining us here today. Such a pleasure to have you sharing your research and all your knowledge with us.
Thanks, Fabiana. It's really great to be here.
So I will give you a moment to share your screen because I know you have a presentation, and right after the presentation, we're going to have a Q&A session. So if you have questions or comments, if you are watching us live from Facebook or YouTube, please send your comments on the comments area below. And right after Samantha, we have Tiffany Richards sharing her experience with preeclampsia.
Okay, perfect. So I'll just...
Okay, so give me a minute to bring this up. Okay, and you can start from your slides from the beginning. Perfect.
Okay, so you can see the screen?
Yes, perfect.
Okay, perfect. So hello, everyone. As Fabiana mentioned, my name is Samantha, and I'm currently a postdoctoral fellow at Queen's University in the Department of Obstetrics and Gynecology. And I'm very interested in understanding preeclampsia as a disorder, as well as elucidating why women are at increased risk of cardiovascular disease after preeclampsia. And this session comes at a very good time because tomorrow is, tomorrow, May 22nd, is World Preeclampsia Day. So it's an endeavor to globally raise awareness of preeclampsia, what it is, and how it affects pregnant people and their babies. So I just have, I just made up a brief sort of PowerPoint presentation just to keep my thoughts in order, because I will ramble on about the placenta and preeclampsia ad nauseum. So this is just to keep me more focused. But today we'll talk about what preeclampsia is, and then we'll shift gears a little bit to after pregnancy and what are the maternal health risks following this pregnancy complication. So the burden of preeclampsia worldwide affects about 5 to 8% of all pregnancies. And this equates to about 76 maternal deaths worldwide and over 500,000 fetal or infant deaths annually. And so the burden of the disease will vary depending where you are located geographically, with the highest mortality and morbidity rates occurring in low and middle income countries. So unfortunately, right now, there is no cure for preeclampsia, and there are limited treatment options available for women who develop this pregnancy complication. And they're mostly related to controlling blood pressure, which I'll get into in a little bit, as well as preventing seizures, which of course is the end result of preeclampsia, eclampsia meaning seizure. So our only sort of option to resolve the syndrome of preeclampsia is to actually remove the placenta. So this will often result in resolution of the symptoms, but it also requires delivery of the fetus, of the unborn baby. And so this makes preeclampsia a leading cause of preterm delivery, especially when a mom gets sick very early in pregnancy. So there are numerous short and long-term health consequences of preeclampsia that affect both the mom and her infant. So for example, prematurity and the sequelae associated with being born preterm is one. And then also preeclampsia, and what I'm going to focus on today, is an indicator of maternal cardiovascular risk after pregnancy. So it's over the life course for both the baby and for mom. So how do we diagnose preeclampsia clinically? Previously, it required the development of high blood pressure or hypertension, as well as protein in the urine, which is referred to as proteinuria. Now, this is quite an old definition for the diagnosis of preeclampsia. And as we've learned more about the syndrome and its causes and its pathogenesis, the diagnostic criteria have evolved. And so now preeclampsia is diagnosed as, again, with high blood pressure. And this is defined as systolic blood pressure of 140 over a diastolic of 90 millimeters of mercury, with one or more adverse features. And the adverse features, as you can see here in this cartoon, include they reflect the diversity of the organs that the syndrome is affecting. So there can be signs and symptoms related to the brain, lungs, liver, kidneys, as well as circulating white blood cells and platelets within the mom's circulation. And there can be consequences on the fetus, mostly abnormal growth. And by definition, these signs and symptoms or the adverse features with hypertension develop after 20 weeks of pregnancy. So before then, you wouldn't, if it developed before then, you wouldn't receive a diagnosis of preeclampsia per se. And in some rare cases, these symptoms can actually develop after delivery in the postpartum period. So as I mentioned, our diagnosis is made upon clinical findings, laboratory tests, as well as signs and symptoms. So sometimes women will experience signs and symptoms that are, again, reflecting the contribution of the organ dysfunction within the mom. So there can be headache. There can be severe swelling in the hands and feet, as well as in the face. There can be difficulty breathing, or shortness of breath, not being able to take a nice deep breath comfortably. The development of nausea and vomiting after 20 weeks of gestation is also a sign and symptom. There can be vision changes, and there can be upper right quadrant pain. And that's reflective of sort of a liver involvement in the pathogenesis of the disorder. The unfortunate thing with preeclampsia is that in some cases, there are no signs and symptoms. So the mom is not aware she's developing high blood pressure or that she's spilling protein into her urine. And so this makes preeclampsia very dangerous because it can become very severe without sort of being diagnosed or recognized. So risk factors for preeclampsia are diverse, and they're heterogeneous and very variable between individuals. So a risk factor for preeclampsia includes your first pregnancy. However, if you have a history of preeclampsia, you also have an increased risk of developing it in your second pregnancy or beyond, as well as if there is a family history on the mother's side. So this would include her mother, her sisters, her aunts. Women who have pre-existing medical conditions such as chronic hypertension or kidney disease are also at increased risk of developing preeclampsia. Obesity and BMI greater than 30 is also a risk factor. New paternity, meaning pregnancy with a new partner or a pregnancy interval greater than 10 years, has been associated with an increased risk. Advanced maternal age or young maternal age, so under the age of 18, is also associated with preeclampsia. There are different ethnicities that have a greater risk of developing this disorder. Multiple pregnancies, so these would be twins, triplets, and beyond, is also a risk factor. Some of the assisted reproductive technologies are associated, and there have been a variety of genetic polymorphisms or genetic changes within the mom that predispose her to preeclampsia. But, and I'm sure you're starting to recognize a theme with preeclampsia, is that it can arise without these risk factors present. So what are the causes of this disorder? And unfortunately, we don't fully know yet. What we do know is that the placenta is required for its development. And the placenta, as shown here in this figure, is the organ of pregnancy that connects the mother to the fetus. And this is where all the exchange of oxygen and nutrients occurs, as well as removal of carbon dioxide and other waste products from the fetus into the maternal circulation. And so it's the critical organ of pregnancy. It's what sustains fetal life. And we know that when there are problems in the placenta, this can lead to preeclampsia. However, exactly what's going on in the placenta, again, as I mentioned, we don't fully know, but it's definitely multifactorial. So there's going to be factors from the maternal side within the placenta itself, as well as the maternal environment that are going to contribute to the placenta, to the development of preeclampsia. So our current understanding of the pathogenesis, so what happens from the beginning of pregnancy to the end in a pregnancy complicated by preeclampsia, is described as a two-stage model. So there's two distinct phases in the development of this syndrome. And the first occurs very early in pregnancy when the placenta is first developing. So after after fertilization occurs, the cell will divide and become the blastocyst, and the outer cells of the blastocyst will develop into the placenta. And this occurs very early in pregnancy. And what happens in the context of this pregnancy complication is that these factors that we're trying to elucidate and recognize, so the genetic factors, pre-existing conditions, will contribute to abnormal development of the placenta. And this leads to an organ that isn't functioning properly as pregnancy progresses. And what happens is we develop a blanket term that we call placental stress. And so the placenta hasn't developed properly, it's not doing its job, and it's going to try to increase its capacity to sustain fetal growth and development. And it does this through a variety of mechanisms. And what happens is that these mechanisms result in the secretion and release of a variety of factors that enter into the maternal bloodstream. And it's actually these factors that the placenta releases that will target the end organs and cause their dysfunction. So this is in the mom. And so this is the second stage of preeclampsia, when we will see the clinical manifestations. So these factors, which we fully don't know exactly what these are or what they're doing within the maternal system, but they will interfere, say, with the maternal kidney and result in dysfunction that leads to protein being released. These factors will also interact with the cardiovascular system and result in hypertension. Now, as with the theme with preeclampsia is that even with this model, we're not really explaining all of the heterogeneity that we see within the disorder itself. And when I'm talking about heterogeneity, all facets can be variable between women. And so this includes the timing of onset. So one woman might develop preeclampsia really early in pregnancy, where another woman might make it to past 37 weeks or even to term or post-term. The severity of how sick a woman will get will vary, as well as her signs and symptoms, the presence or absence of risk factors, and pregnancy outcomes will vary as well. So this, like how early was delivery? Did the mom develop a seizure? And also within the placenta itself, which is where I'm particularly interested in, is when we look at the placenta after delivery, sometimes there's massive amounts of pathology. So meaning we can see that, okay, there was placental dysfunction. We can see that the interior bits of the placenta haven't formed or developed properly, and that's contributing to the preeclampsia. But then sometimes we get a placenta and it looks completely healthy, and it looks like it could have come from an uncomplicated pregnancy. So this model isn't explaining everything that's going on within the syndrome. And this has led myself and other researchers to propose that preeclampsia isn't a one-size-fits-all. So we really we can think of it as sort of an iceberg. We see these common late-stage pregnancy clinical manifestations, say high blood pressure and organ damage. But underneath, we have so much more going on. And what exactly is going on is what is the focus of many research groups across the world. And so there's a revised hypothesis that preeclampsia is actually not a single disorder, and there is no common pathophysiology. And really what's driving the development of the late stage clinical features are very distinct different pathways of disease. And so what happens is underneath this iceberg, you'll have these distinct pathways that start from different origins or are related to different pathophysiology that lead to this common clinical manifestation. And, I forgot to mention, and what we would refer to these distinct pathways or these groups are as disease subtypes. So within preeclampsia as a whole, there's these distinct subtypes. And why is it important to recognize and start to identify these subtypes? So really, to reduce the burden of disease on mothers and babies, we need to be able to identify women at risk early, ideally before pregnancy, so that they can be monitored appropriately. We need to be able to diagnose preeclampsia accurately. So, if a woman is coming in with high blood pressure, but then the other organ dysfunction isn't picked up by chance, that this could lead to a misdiagnosis and quickly and rapidly result in maternal decompensation. And we need to develop and identify new treatments, management interventions for these pregnancies to improve outcomes. And really, the reduction in the disease burden will be advanced by understanding these disease subtypes, because we can attack each one with a targeted approach. This is getting into other areas of medicine where it's very personalized and it's individualized to what your disease state is. And so how do we find these disease subtypes? And this was some work that I did at the University of Ottawa with Dr. Shannon Bainbridge and our colleagues in Toronto, where we tried to identify these disease subtypes concretely and using very robust clinical and placental data. And so typically what happens is there'll be a study and they're looking to compare an outcome or an intervention. And the researchers will compare women with preeclampsia versus controls, typically healthy, sort of uncomplicated pregnancies. Now, the problem with grouping all women together into one group of preeclampsia is that you're potentially losing the important messages that disease subtypes are telling us. So you could say have this new therapy to try, you test it in your cases, and you get variability in the data, you don't see any effect. And it might be because you're actually losing granularity when you treat the group as a whole. And so what we did in this particular study that I'm going to highlight is we used an unsupervised approach with a cohort of preeclampsia cases that were diagnosed across the clinical spectrum, meaning that we are really taking all the heterogeneity and trying to build this cohort of preeclampsia cases. And so this is just a breakdown of the cohort that we had. So we had 157 women who were either not diagnosed with preeclampsia or who were diagnosed with preeclampsia. And you can see that there was, differences in the gestational age, so term, preterm, whether they had pre-existing chronic hypertension before pregnancy, and then how their babies grew in utero, so AGA being appropriately grown and SGA being small for gestational age. And so from these women, we collected placental tissue, and we looked at gene expression within these placentas. And the way that the data was analyzed by our very smart colleagues in Toronto was they took an unsupervised clustering approach where they put the gene expression data into the computer program, and they told it to identify groups of placentas that were similar and then very distinct from each other. And when we looked at the data and the outputs from this, we found that all the placental cases grouped into 3 very distinct clusters. And so the next step was to look at these clusters and really robustly phenotype them. So we looked at clinical data, so risk factors, maternal age, their weights, heights, how sick they were during their pregnancies, what were their pregnancy outcomes. And again, driving the analysis was the gene expression within the placenta, but then we also looked at the organ itself. So we looked at histopathology, so placental pathology. So we had slides and we looked at what did the placental tissue look like underneath the microscope. And from this, we were able to phenotype 3 distinct subtypes of preeclampsia. So again, remember that all of these women would have high blood pressure with at least one feature of other organ damage. But what we found was that there was one group that really had no overt placental pathology, but they seemed to have underlying cardiovascular dysfunction that was likely leading to the development of preeclampsia. Another very distinct group was one that displayed histological changes, so that's at the tissue level, and gene expression changes related to placental hypoxia. And that's just a term to mean low oxygen. And so this might be related to more of our pathogenesis model, where the placenta doesn't develop properly and there's not enough oxygen coming into it to sustain its function as well as the developing fetus. And then lastly, there was a third very distinct group that had placental gene expression changes and histopathology indicative of inflammation. So this was in the placenta. And it's perhaps that this inflammatory response in the uteroplacental unit that was driving their development of preeclampsia. So outputs from this work, we have our 3 groups, and now what? And so as research progresses, you take your findings and then you need to confirm your findings. So we're working at confirming these disease subtypes in other populations of women with preeclampsia. We also need to identify and develop easy, cost-effective ways to identify these subtypes of preeclampsia in the clinic, which is some work that's underway right now. And then to improve the outcomes for women affected by preeclampsia, we need to really take a targeted approach at the underlying pathophysiology by the subgroups and conduct trials to see if we can improve outcomes by the disease subtype. Okay, so I'm going to switch gears a little bit and move into the postpartum or the period after pregnancy. And really, I'm focusing today on maternal cardiovascular health after preeclampsia. So worldwide, cardiovascular disease is the #1 killer of women, and data shows that it's responsible for 1 in 3 deaths of women. This surpasses the number of deaths in men. It as well surpasses the number of deaths by all cancers that affect women combined. And what we're learning is that what happens in our pregnancy can be an indicator or act as a snapshot into our future health. So women that develop preeclampsia during pregnancy, which is a hypertensive disorder, are more likely to develop cardiovascular disease later in their lives. Now, we have evidence for this at the population level, and the data is actually quite shocking. So compared to women who do not develop preeclampsia during their pregnancies, there's women who do develop preeclampsia have a 2 to 4-fold increased risk of chronic hypertension. So this is developing it later in their lives. They have a 3-fold increased risk of stroke. They have a 2.5-fold increased risk of coronary artery disease, and they have a 2 to 9-fold increased risk of dying due to cardiovascular related issues. Now, the variability in this risk seems to relate to disease severity. So women who develop very severe early onset preeclampsia are the ones at the highest risk of suffering cardiovascular related deaths. And really alarmingly is that these cardiovascular events are happening much earlier in life than in the general adult female population. And so one study, a landmark study coming out of Canada that followed over 1 million women by their pregnancy outcomes, found that women were experiencing these cardiovascular events at 38 years of age, which is extremely young to be, having a stroke or dying because of a heart attack. I just want to also point out that these trends in cardiovascular disease following a pregnancy complication are also found in other circumstances. So women who develop or who deliver a growth-restricted baby but remain normotensive are also at risk of increased cardiovascular disease later in life, as well as those who deliver a preterm, not related to, say, preeclampsia, as well as women who develop gestational diabetes during pregnancy. So it's not just preeclampsia itself that are associated with these adverse cardiovascular outcomes. So what's actually happening here? What is preeclampsia telling us? And the current thinking is that pregnancy is acting as a stress test. And it's really showing us those women who have underlying cardiovascular vulnerability that will lead to cardiovascular disease later in life. It's just pregnancy is happening earlier and it's unmasking this vulnerability and giving us insight into what might happen later on. So there are a number of physiological changes that occur in pregnancy that are needed to support the mom in her preparation for, say, labor and delivery, as well as support fetal growth and development. So these changes need to happen. It's a physiological change. But some women don't seem to be able to handle those changes as well as others. And it might be related to underlying cardiovascular risk. And so this graph is just showing you have your average, uncomplicated or healthy population in the blue, and women with underlying risk factors will, develop preeclampsia during pregnancy, and then they're at increased risk following because of the presence of these risk factors. And so now that we've recognized this, we have the population data to show us what can we do about it? How can we use pregnancy and the postpartum period to improve the health of women as they age? And it's really now the focus to target screening lifestyle modification, and early treatment, such as with blood pressure medication, as early as possible, because this postpartum period seems to be a time in which we can really change the trajectory of these outcomes. And so I'm just briefly going to talk about, what's going on in Canada. But first, I just want to highlight, overall, this has been a missed opportunity, and we're really only starting to take what happens in pregnancy as a risk factor for future cardiovascular health seriously. So even though we know that there's this association between what happens during pregnancy and health afterwards, there's still not a lot being done. And it's quite shocking to hear that there are healthcare providers. This might be due to the fact that healthcare providers just aren't aware. I think that the most recent statistic is about 50% of primary care providers don't know that events in pregnancy are important indicators for future cardiovascular health in women. There are issues with resource availability. So to have screening and follow-up of all women with preeclampsia requires a number of clinicians, a number of clinical services that might not be available in certain places or set up yet. And also there's a lack of understanding on the side of women themselves. So most women, I think that statistic is about only 20% are aware that of events that happen in pregnancy and their association with health later in life. And so I think this is actually just playing into overall how cardiovascular disease in women is respected worldwide. So this was a recent publication from The Lancet, a commission to improve cardiovascular health in women. And they cite this cardiovascular disease in women being understudied, underrecognized, underdiagnosed, and undertreated overall. And so add pregnancy in there and it just gets a little bit worse. But I'm happy to say that there is a national movement in Canada to improve this. And so this is coast to coast, a movement that started to really target the postpartum period as a critical window to improve cardiovascular health for women. Now, I'm just highlighting the names of 3 clinician scientists who are working at this right now in Canada. There are, I believe the movement has 18 sites across our country that are working together to really develop guidelines, to develop how the clinic should run, optimal timing for screening and interventions. But we have Dr. Kara Nierenberg in Calgary, who's actually the leader of this national movement, Dr. Graham Smith, who runs the Maternal Health Clinic in Kingston. So this is a postpartum follow-up clinic for women who develop any pregnancy complication. So they'll go and see Dr. Smith at 6 months postpartum. They'll be screened for cardiovascular risk, and depending on how they screen, they'll be given certain recommendations to mitigate their high risk status, say. And then there's also a physician in Hamilton, Dr. Serena Gundy, who runs a similar postpartum cardiovascular health clinic for women who develop preeclampsia. And so really this national movement, which is called the Canadian Post-Pregnancy Clinical Network, proposes a model where women are cared for during their pregnancy, and they're moved through a process of primary care that's supported by interventions and educations, both on the side of the clinician and the woman herself. And there's dedicated resources and supports to really start intervening early in these cases to really reduce the burden of cardiovascular disease in later life. And then this is just one quick slide on some of the work I'm doing. Again, relating back to the placenta, because that's where my true love lies. But what we're looking at is, can we identify ways to risk stratify women at the time of delivery? So knowing in our healthcare system, being able to screen all women who develop preeclampsia likely isn't feasible. And so really at the time of delivery, can we identify the ones who are at the highest risk, who really need to be seen by these dedicated postpartum follow-up clinics. And so one study that we have coming out, the paper's just been written and we're submitting it for publication, is that when we looked at women who developed preeclampsia in pregnancy, we collected their placentas and we looked at their histopathology underneath the microscope. They were then seen again 6 months postpartum, and they were screened for cardiovascular risk at the 6-month clinic visit. And they were either screened to be high risk or low risk. And then when we looked at what the placentas looked like between these groups, we found that women who had a certain combination of placental lesions. So placental lesions are the individual pathologies that we can see underneath the microscope. There was a 3 times increased chance of screening high risk at the 6-month visit. And so really this brings about an idea to use the placenta and placental pathology, which is already being done in the clinical context, as a way to risk stratify women at the time of delivery. And so we'll be following these results up in larger trials. So that was just a brief overview of preeclampsia and maternal health risk following preeclampsia, but really the take-home message is research is moving forward to identifying subtypes of preeclampsia so that we can advance treatments and interventions for women and babies affected by this disorder, which is vitally needed. And also, we really need to work collectively to increase awareness of how pregnancy complications translate into cardiovascular risk in the postpartum period. And so I'm happy now, thank you for listening, and I'm happy now to take any questions.
Okay, Samantha, thank you so much. Yes, perfect. Thank you so much for
You're welcome.
Your knowledge, your expertise, and certainly your passion. I have here a comment. It's how important your study is. Jessica, how do I go to study? Jessica is a preemie parent, and she always attends our sessions on Friday. So thank you, Jessica. But this really shows how important it is, and obviously a lot of interest. And I think today, as in many other days, is an important day to raise awareness on preeclampsia. Tomorrow is World Preeclampsia Day, as you pointed out. I think my question to you is, because it seems like only 3 places in Canada is still doing the postpartum screening. So how the women who had preeclampsia, how can they be screened to access if they are high risk?
So I'll just clarify, those are only 3 of the 18 clinics in the country. I just didn't have room to name everyone. But again, the size of our country, 18 clinics, just is not enough as it is. So if I was in a city that doesn't have one of these clinics, and I was, say, telling a friend who had preeclampsia, I would be telling her to go to her family doctor and advocating for either referral to a more specialized like cardiology clinic, or even just having the primary care provider do the assessment. So they can screen for blood pressure, they can prescribe antihypertensives. They can look at kidney function with dipsticks in the office. But really, I think because there isn't a standard in these clinics across our country, it really kind of falls on the patient themselves to advocate for themselves. To get these screenings done and these tests done.
So
unfortunately,
from my own personal take is like how important it is for us to really talk to family doctors about our history. Because I think this is something that, okay, like this happened before, a few years later, you kind of put on the back of your mind, and the disclosure of your medical history for doctors, if you're planning to get pregnant again, or even if you're not, is still very important, right?
Yeah, and you know what, I think it shouldn't all just fall on the patient to bring this up to their doctor. There needs to be more training and awareness for family physicians, say, or nurse practitioners themselves when they're learning this, say in medical school or in nursing school, where they're really taught that it's important to ask a woman, Did she have a pregnancy complication? Did she deliver preterm? These just aren't standard questions that are asked yet. But should be.
After I talked to you, preparing for this interview, women who deliver early is at risk of cardiovascular disease. And I actually brought it up with my family doctor because I have a new family doctor. I didn't know that I had to premium, but this was not even in our conversation. So I think educating, honestly, our parents and our population is very, very important, as well as the clinicians that work with our community. We have a question here from Daniela. Thank you, Daniela, for joining us. Is it too late after 6 months? Should still do this?
Yes, definitely. It's not too late. You know, and part of this new, this Canadian national network is to conduct studies to find when the optimal time is. Right now, it's just 6 months because that's when someone decided we should do it. But earlier is probably better, but it's any time is better than never. So, you know, even if you're a few years out after having your preeclampsia, I would still be bringing it up with your family physician or your nurse practitioner the next time you're, say, in the office or when you have your annual physical, those sort of things. It's not too late.
Okay, so I have another comment here from Sarah. So interested and important to learn about all this. I had developed HELLP syndrome and I had no follow-up once discharged from the hospital. Hearing all this makes me realize how much more I should be doing. Thank you, Sarah.
Yeah, thank you. I should also point out, Sarah, that it's also the healthcare system's responsibility to be, you know, telling you what your risks are. And so, you know, raising awareness with clinicians is just as important as raising awareness with women themselves. And the data supports your experience where physicians don't know, women aren't aware, and then, you know, 10 years later, there might be a cardiovascular event that could have been prevented, say, with screening and, you know, lifestyle modifications that were recommended, for example.
Yeah, so I have one more question. Can we reverse any of these effects or rather stop it from getting worse?
Yep. So cardiovascular disease is modifiable. So there are a variety of lifestyle modifications that can be made. So, you know, the big ones being cessation of smoking, diet and exercise regimens. There also seems to be evidence that starting antihypertensives early for women who maintain their high blood pressure after pregnancy is beneficial. And of course, if we can reduce or lower blood pressure, that stops a lot of other bad things from happening or associated with high blood pressure. So there are definitely modifiers that can be done to mitigate the risk.
Okay, so now I'm going to share here some resources that you mentioned, a lot of resources from EFCNI, the European Foundation for the Care of the Newborn Infants. They have a whole page dedicated to preeclampsia, and that is great. A lot of great visuals. And also have the Preeclampsia Canada. I'm sharing here the website. They also have a lot of resources, the latest in research and what is happening in Canada. So tomorrow we do have the World Preeclampsia Awareness Day. I'm going to share here the EFCNI social media poster that we can share on social media to raise awareness across the world, all in our social media channels. I think it's very important that women know this can be a condition while they are pregnant. So let me see if there is one more comment. So Daniela just say thank you very much. And I also want to thank you, Samantha, for joining us here today. Such a great and informative session. I'm so looking forward to keep following you and see what else is in the research and what else is coming in this area. So I hope I can bring you back next year. So thank you so much.
Yeah, you're very welcome. Thank you for having me.
Thank you. And now we are going to have Tiffany Richards joining us. Tiffany is a parent who delivered preterm, and she's going to share with us how preeclampsia and HELLP changed her life. In her own words, Giving birth so early due to preeclampsia changed my whole world and perspective, giving me a passion for helping others in their ICU journeys, as well as healing physically and emotionally after suffering from preeclampsia. Tiffany Richards is the only parent. Her son, Knight Boston. Let me bring Tiffany here.
Hello.
Yeah, so Tiffany. So I'm gonna, Tiffany, if you lower your volume just a tiny bit. Okay, maybe it's better. When Tiffany was 27 years old, she was pregnant and gave tonight at 27 weeks gestation. She spent 100 days in the ICU at the Women's Hospital in Winnipeg, Manitoba. Tiffany works at Canadian Blood Services. She has a love for animals and plants. Her son is now thriving. He's 18 months old, and prematurity might have made him a little small, but it hasn't slowed him down. And Tiffany also just joined our Parent Advisory Committee here at the Canadian Premature Babies Foundation. We are so grateful, Tiffany, that now, after this bumpy journey that you had, you are here supporting other families. So thank you so much for joining us here today and share your story.
Thank you for having me. And I also want to say thank you to Samantha. That presentation was fabulous and so informative.
So Tiffany, let's start. When did you first learn that you might be at risk of preeclampsia, and what symptoms did you experience?
So I had hyperemesis gravidura my whole pregnancy. So I threw up all the time. Really early in my pregnancy, a midwife had first mentioned to me preeclampsia because I had a high blood pressure reading. Previous readings had been normal, following readings were also normal, and this is really early in my pregnancy, around 17 weeks. 10 weeks later, my son would be born, which is crazy to think looking back. But so a few weeks go by and my sickness in terms of vomiting just gets worse and worse, and it's no longer being controlled by medication. And it's interesting to hear Samantha's presentation about the onset of high blood pressure with one adverse effect. So I started off with the high blood pressure and protein in my urine, which quadrupled over a 2-day period from when my midwife tested it to when I was admitted to the hospital for the first time. So that was at 24 weeks that she tested my urine, and that I was also admitted to the hospital 2 days later. And again, like the lack of symptoms for me, I didn't feel any differently because I was so sick the whole pregnancy that I just felt the same. And so it was just, everything started to snowball. First it was the protein in the urine, then my liver function, then my kidneys were failing, then my lungs were filling with fluid, and then I started having blurry vision and like seeing spots. And at 27 weeks, I finally developed HELLP syndrome and had a seizure, and that's what led to the birth of my son.
So Tiffany, while you were sick, were you aware that you could deliver earlier? Because this is something that I hear from a lot of families, and my own experience, even when you're sick during pregnancy, the fact that you can deliver early is very little discussed with families.
Yes, I feel I was almost led to believe that I would be pregnant for a lot longer than I was going to be. It was actually the day before my son came that I was told, look, we need to just push your body as far as we can to let this baby grow as much as we can before you have to give birth. And that was really the first time I had heard that like giving birth could be any time now. And then it was the next day. So I was in the hospital for 13 days. And not once in those 13 days prior was I told, hey, your baby's going to be coming soon. Sorry, I get really emotional.
Absolutely fine, because it is a very emotional roller coaster for sure.
Mm-hmm. So yeah, I feel I was not informed that I was going to be having a premature child.
So when your baby arrived, how were you feeling then?
Really defeated. You feel like your body's failed you. You're scared. You're so scared. And I don't know what everybody's birth is like, but I didn't know for a good 4 hours after having him if he was even alive or not. And yeah, there's a lot of emotions that go with it. There's anger, there's sadness, there's a lot. Like, you have to almost grieve the pregnancy you thought you were going to have. So it's really complex going through that, for sure.
And how were you physically? Because you had all this sickness during the pregnancy, then you had the preeclampsia. How, after you got discharged from the hospital, did you have any follow-ups? How did you feel physically?
My blood pressure almost returned to normal directly after birth. So I was discharged 48 hours after my son came. And I was followed up for about a week with a nurse practitioner. She would call every day and I would check my blood pressure at home. And they continued me on the hypertensive medications, but I only needed them. I stopped taking them after 3 days because it was making my blood pressure too low. So I also had a lot of swelling after giving birth because of the magnesium that they gave to protect my son's brain after I had a seizure. So that caused a lot of swelling. So I was a little uncomfortable, but otherwise my health returned to normal and there was no more vomiting, no more headaches, no more blurry vision, none of those things. So it's interesting to find out as a mother who suffered preeclampsia that there is or could be future cardiovascular issues to your health in the future.
So that's Tiffany, because you're so young, you're 27 when you delivered, which was a year and a half ago. Were you aware of this, or any of your doctors after the first 6 months of follow-up alert you from those risks?
No, not a single one of my doctors, not my obstetrician, not my family doctor. So no, what I know based off is just based off reading I've done on my own and research I've done on my own in terms of future risks.
So now you know have to be proactive, and I have Samantha here listen to your presentation and the back room, and I'm sure she knows there is a lot of work from the research to do. And then I'm going to bring her back here to make a final comment. But if you're watching us live, you can read Tiffany's full story. She wrote a blog to us on our website, CPBF. I'm just sharing the link on the comments because she goes very deep into her story and her feelings and her journey in ICU with her son. So Tiffany, how is he doing now, a year and a half later?
He's incredible. He's so much fun. He's starting to talk. He's been walking for a while now. It's been an incredible journey with him. He's so strong.
That is amazing. And Tiffany, let's talk about why it's so important for you to raise awareness. And do you have any tips for parents who are listening to us today?
I guess it's important for me to raise awareness because I almost lost my life to preeclampsia. Prior to my pregnancy, I never knew much about it at all. And I think it should be a common discussion at your obstetrician appointments. You should know about it early in your pregnancy. You should know what to watch for signs and symptoms. Protein urine testing should be done regularly for women who have risk factors. So I want to say to women who are pregnant or who do have risk factors for preeclampsia to advocate for yourself, to ask for these tests to be done, and just stay on top of your health as much as possible and be involved in your care as much as possible.
Absolutely. Let me bring Samantha back to our broadcast room. Samantha, you can unmute yourself because I know you have a comment here.
Yeah, I just wanted to say thanks, Tiffany, for sharing your story. As a researcher, I'm quite removed from actually interacting with women, patients. You know, I get placenta samples in the lab.
Right.
So it's I might get a little bit teary-eyed. It's just really touching and, you know, just emotional to hear your experiences, that this is it's such a devastating condition in pregnancy.
Mm-hmm.
And, you know, as a, you know, really just puts in why I do what I do. And if there can be a world one day where there's a cure and no one ever has to suffer, you know, a seizure and being in the ICU and with a baby in the NICU, it would just be such a wonderful thing.
Yeah, thank you so much for your research and helping raise awareness for this condition, because like you said, it is devastating for a lot of women, and there's a lot of women who aren't as lucky as I am who lose their lives and whose babies also aren't as fortunate as my son to be thriving from being born so early. So thank you.
Wow, I just love this moment because this is the whole goal of CPBF is always to bring parents, clinicians, research to the same table, because I think we learn so much from one another. But I think
Yes.
it also gives you, put the numbers that you have into the reality. Each number is one story, each number is alive and is a family. And I think it is so important. And I always love when this happens and we are all together talking and raise awareness of topics that are important to us and important for families and for the researchers. I think I have one comment here. Tiffany, we have a comment from Lee. Thank you so much for sharing your story. And then from Sarah, Tiffany, I appreciate so much what you're saying. I was in and out of the hospital 3 times before I had to have an emergency C-section. Things weren't explained to me until after surgery. I didn't get to meet my son for 2 days until they had my blood pressure controlled. I truly wish I had known more about it before, because of course we question ourselves thinking, what did we do? Thank you, Sarah, for sharing that. For sure, as the parent carrying the baby, you always have some guilt. What have you done? Or what could we have done to prevent it? But this is something that is out of our control, really.
Yeah. And I just want to say to every mom who's given birth early, regardless of why, whether it's preeclampsia, prom, whatever, it is not your fault. It is not your fault. You are the best parent for your baby, and that's the most important thing. It is not your fault.
Absolutely. So, Tiffany, thank you so much for joining us here today from Winnipeg. I hope you have a nice long weekend in your city. And Samantha, also, again, thank you so much for joining us here today, sharing your knowledge and expertise. I'm so grateful to both of you for taking the time to share this message and very important day tomorrow, World Preeclampsia Awareness Day. So thank you, both of you. And I see you all again very soon.
Thank you so much for having me. Have a great weekend, everyone.
Thank you.
And for all of you watching us live on Facebook or our YouTube channel, thank you so much for joining us here today. The video of today's session and all the videos from our live series are available on the CPBF website, which is right here, the Canadian premis.org. I want to thank our sponsors, AbbVie and Water Wipes, for their ongoing support for our education sessions. And we are a charitable organization, and we believe that through education and support, we can empower families, ensuring they are ready to care for their premature babies. Visit our website, consider making a donation. Together, we can create a brighter future for all our families. So I see you again next Friday, 1 p.m. Eastern Time. Stay well. Thank you.